Hello, you're welcome to my channel. I am Dr. Sandra. I am a medical doctor and a surgeon. I am all about creating awareness and sensitization among my patients and the general population, especially about the different surgical conditions. Today's video is about an entity of ulcers that is caused by a prolonged exposure to external pressure resulting to necrosis and ulceration. This ulcer is what we call the pressure sore, bed sore, decubitus ulcer, or trophic ulcer. These terms are used interchangeably, but they mean the same. Essentially, we are supposed to have a consistent supply of blood to our areas where there is pressure exerted. Even though we have some pressure in some areas, exertion of some pressure in some areas, especially in some positions that we tend to assume. For example, if we've assumed a sitting position or a sleeping position, we tend to have some pressure in those areas in such a setting. However, this pressure shouldn't exceed 30 millimeters of mercury, this external pressure. If this external pressure exceeds 30 millimeters of mercury, there is going to be a cessation of blood flow to these areas. And then we end up with hypoxia, that is a reduction in oxygen concentration in those areas, and we end up with ischemia and then necrosis. Necrosis, by the way, is cell death, tissue death. And that is how you end up with these ulcers, the pressure sores, the pressure ulcers. Inherently, these ulcers are usually deep, chronic, and painless. They are usually deep because of the way they are formed. They are usually formed from the skin, and sometimes they can even erode to the bone. By the way, the layers of the body include, in majority of the parts of the body, they include the skin, which is the first, subcutaneous tissue, which is just below the skin, the fascia, the muscles, and then the bone. The initial lesion that sparks off the formation of a decubitus ulcer, a pressure sore, is usually a callus, what we call a callosity formation. That is hardening and thickening of a given part of the skin where there has been continuous pressure exertion or continuous trauma to that area. So you tend to get thickening and hardening of that skin, that area of the skin. The other thing that happens after that is formation of pus under that callosity, that callus. And when there is pus formation, it tends to give way and erodes through the different tissue planes I've told you about. It goes to the subcutaneous tissues, the fascia, the muscles, and to the bone through a central hole, a tunnel, some kind of a tunnel. It is almost as though someone came and scooped part of your tissue and took it away. They are so deep that it almost looks like some tissue was lost, some tissue was scooped out, but it is all about how it is formed. The areas where we get these ulcers include the bone, where we have bony prominences. For example, at the back of the head, the occiput, we can have them at the back of the shoulders, the sacral region, the posterior part of the waist, the gluteal region, that is the buttock region, and the heels of the foot. This is because there is usually a compression of the tissues between that bony prominence and the external object. For example, a hard bed. That is what happens majority of the time. The patients that are usually affected are the hospitalized patients. By the way, these ulcers tend to occur among 5% of the patients that are hospitalized in the hospitals. And these patients can include patients that have poor blood supply. For some reason, maybe they have arterial disorders, patients that have neurogenic deficits, neurogenic disorders, maybe they have a spinal injury, they are paraplegic, they are quadriplegic, they have diabetes mellitus, they have leprosy. There are also patients that are malnourished. Malnutrition has a way of depleting the fat depositions, the fat stores. Remember, fat is supposed to cushion your bony prominences. So when you're malnourished, there is a way you tend to have your bony prominences just open to the tissues, the other tissues like the skin. And any external pressure can easily cause a decubitus ulcer. Patients that are unconscious for some reason, maybe they've had a severe head injury, they can also get the ulcers because they cannot easily turn. They are always in one position unless they are turned by an attendant or a health worker. Patients that have urine incontinence, fecal incontinence also are predisposed because fecal matter and urine have a way of macerating the skin, and this maceration can actually be a precursor for the formation of these ulcers. The investigations we carry out in these patients include a discharge study, where we do some investigation on the discharge that comes from this ulcer. That can be culture and sensitivity, gram staining, ZN, and cytology. We can also do a random blood sugar, or we can do sugar levels. So you can either do random or fasting blood sugar to make sure that you're not battling any underlying conditions like diabetes mellitus. We also do age biopsy. We biopsy the age of the ulcer to make sure that you're not battling any cancer and we are unaware. We also do X-ray of that part to just make sure that you don't have any underlying bone infection, because bone infection also has a way of derailing your healing of that ulcer. We can also do X-ray of the spine. The management includes, we have to manage the underlying condition. If you're diabetic, we have to optimize your sugar levels. If you're malnourished, you have to manage your malnutrition, and so forth. The other thing that we can do is we give you antibiotics. We also do something surgically, what we call the debridement, where we excise all the devitalized tissues, the necrotic tissues, the slough, and after that we can do what we call ulcer cleaning with the normal saline and antiseptic agents. We can also do what we call dressing of the wounds. Depending on how bad the contamination is, we can do it twice daily if there is too much contamination, or just once daily if there is minimal contamination. There is a very good treatment modality that has shown to improve and accelerate the healing of these ulcers. It is called the vacuum assisted closure. It is a modality that uses negative pressure to relieve edema from that area. And when the edema has been extracted, it has been reduced in that area, we tend to have a very good blood flow to that area. And a very good blood flow means that we can easily continue with the stages of ulcer healing. That means the cells can easily proliferate, the granulation tissue can easily form, the fibroblasts, of course, will lay down the granulation tissue, the collagen, endothelial cells are going to grow, they are going to proliferate, keratinocytes are going to proliferate. It is all about reducing the swelling. It reduces the swelling in that area to allow blood to go to that area to enhance the growth of these cells. It is a very good treatment modality. Majority of the time, it can be the only thing we use for the closure of these wounds, but sometimes we can also employ other surgical interventions like skin grafting and skin flaps. By the way, even in debridement, after debridement, we do skin flaps and skin grafting. That is what we do for those patients for the management part. These are my take-home messages to especially the people that are taking care of these patients. Please make sure that you turn these patients in bed, especially 2 hours apart. For example, a patient was sleeping on the right. After 2 hours, please turn them to the left. They were sleeping on the left. After 2 hours, turn them to the back. Let them sleep on the back. It is all about making sure that the part of the body that was subjected to the external pressure is now to receive blood when you turn this patient. Especially that in the previous 2 hours, it was not receiving enough blood. When you turn the patient, because the pressure is relieved, the external pressure is relieved, this area will get blood supply, and so we shall not have any formation of these ulcers in such a patient in that area of the body. We can also employ pressure dispersion cushions, whereby you put some pressure dispersion cushions maybe at the occiput, behind the shoulders, the gluteal region, the heels. They help to distribute the weight of the body of the patient, and this allows protection of the areas that are prone to getting these ulcers. They are very good. You can as well employ an air mattress, a water mattress. The other thing that you can do is make sure that you do what we call skin monitoring and observation. You inspect the patient's skin to make sure that you don't have any moisture on the patient's skin, because moisture means that you can easily get maceration of that skin. You can easily get infection in that skin, and then you get an ulcer. We also inspect for any dirt. Make sure that the patient's skin is always clean, especially when it comes to waste, urine and fecal matter. Make sure that the patients have a catheter placed in, a diaper is they are dressed in a diaper, and when time comes for cleaning, make sure that you use something that is gentle, a cloth that is gentle and smooth, so that you don't cause any irritation and damage to the skin, because any damage can be a precursor for the formation of a decubitus ulcer. The other thing that you can do is optimize the diet of these patients, because optimizing the diet means you're treating malnutrition, you're rejuvenating the fat stores in this patient to cushion those areas, and also to enhance the healing of this ulcer. You can as well, we also employ psychotherapists. We always recommend that attendants are open to inviting a psychotherapist to talk to these patients, because most of the time, these patients are actually depressed patients because they have been battling these conditions for a long time. Yeah, that is all. There is not so much about decubitus ulcer. That is all I wanted to tell you. That is what I wanted to share with you. For those of you that have subscribed to my channel, that have liked my videos, that have commented, I am here to say thank you so much. Thank you so much for subscribing. Thank you so much for liking. Please continue sharing my videos, continue commenting, continue subscribing, continue liking my videos, and I will see you in my next video. Bye.